Thank you all for coming. My name is Linda Pellis. I'm the Director of Public Relations for the American Academy of Ophthalmology. Sorry. Thank you for coming to the annual meeting and for coming to this press briefing to discuss the launch of the IRIS Registry. IRIS stands for Intelligent Research Insight, and it is the nation's first comprehensive eye disease and condition patient database. We are fortunate to have with us 4 experts in the IRIS Registry, as well as registries used by the American College of Cardiology. First we have Dr. William L. Rich III. He is the chair of the IRIS Registry Measure Work Development Work Group and the Academy Medical Director of Health Policy. And we also have Dr. David May. He is the chair of the Board of Governors of the ACC. He's also the managing partner of the cardiovascular specialists, and as well as member of the ACC's Pinnacle Registry Steering Committee. Michael F. Chang, and he is the professor of ophthalmology and medical informatics at Oregon Health and Science University, as well as the chair of the Academy's Medical Information Technology Committee. And Tim Parr from FigMD, who is our technology partner involved in the development of the IRIS Registry and was also involved in the development of the Pinnacle Registry for the ACC. Dr. Rich will discuss why the Academy is building the registry and then what the benefits are to ophthalmologists and patients. Dr. May will discuss how registries have helped the ACC. And then we'll go back to Dr. Rich to talk about the regulatory benefits of the IRIS Registry. Dr. Chang will talk about current developments of the IRIS Registry as well as developments for the future. And then we will have a live demo, a very brief demo of the IRIS Registry, and then we'll open it up for about 20 minutes worth of questions. So without further delay, Dr. Rich.
Thank you, Linda. I think the major question is, why are we doing this? Briefly, it's part of our culture. Ophthalmology has been involved in quality improvement. Did the first randomized clinical trial in 1950, where we figured out what caused blindness in children, newborns. Arnold Patz won the Lasker Award. If you go into randomized clinical trials, the gold standard was the diabetic retinopathy treatment trial. If you look at the first comparative effectiveness trial, it was the CAT trial. Comparative effectiveness treatments in AMD. And lastly, the largest advance in public health in the last 50 years was by Al Sommer, where he decreased newborn blindness 50% and newborn mortality up to estimated 30 million babies. So it's part of our culture, same as it's part of the culture of ACC. And this is a propitious time to initiate a registry. The registry is basically a quality improvement activity to get improved quality, get better outcomes, satisfy regulatory needs of the profession. And I think that the important thing is that this is really different. We've learned from the leaders in registry development, ACC, Society of Thoracic Surgery. And what we've done is we've built on their templates. If you look at thoracic surgery, they looked at the results of coronary bypass grafts, and it's a superb quality improvement tool. However, the impact on those after 90 days is not known. They're buying death files from the Social Security Service to figure out what happened to their patients. So this registry is very different. It's built on the outpatient and the longitudinal ability to follow patients. We have a big advantage over Dave in cardiology, where there's many people that will follow someone with ischemic heart disease. It's basically one profession. We're able to follow patients longitudinally, and now we have the technology, thanks to our technology partners, of overlaying the interventions, new treatments in macular degeneration, cataract, glaucoma devices. So this is really a game changer. And I think the number one is the technology is now available to merge these data sets. And so I think that's a very succinct summary. Technology is there, the desire is there, part of our culture, and this is the largest financial commitment. This Academy is the oldest specialty society in the United States, first one with boards. This is our largest financial outlay, so that'll give you an idea of how important the leadership thinks this is. So I'm going to turn this over to Dave.
Good morning, everybody. My name is David May. I am the token cardiologist here, as you can tell, at this meeting.
I'm over 65, that's why he's invited, you know.
Yes, this is in fact the blind leading the blind, no pun intended. My reason for being here is to provide, if I can, a bit of context about IRIS and its significance. It is, of course, another registry. Everyone would view it in that fashion. But let me tell you that it is not just another registry. Registries began many years ago as a way for us to monitor diseases which were very rare. There was no way to collect large groups of patients in one place, and so we began to codify those records and share them. That led to efforts over the course of the last couple of decades to engage in the recording of our common diseases in a unified fashion. The American College of Cardiology has done that in a variety of ways. We have registry systems which allow us to track procedures, angiograms, bypasses, implantable defibrillators. We also have registries which allow us to monitor disease processes, common ones in the outpatient setting. But as Dr. Rich alluded, the ophthalmologists are smarter than we are. Not only did he pick diseases which happen during the day, as opposed to me, I seem to pick diseases which occur at 2 o'clock in the morning and I've got 90 minutes to get there, which is poor planning. But our registries don't let us follow longitudinally. IRIS is, in my opinion, as someone from the beginning of Pinnacle involved to the present, a next generation registry. It allows my ophthalmology colleagues to follow a patient with a disease process to a procedure, back from the procedure, and then continue forward. That's unprecedented. That will, I believe, revolutionize the way that we view registries. It is what we would like to do. Registries, it is important to understand, are clinical material. These are not claims-made data. These are important clinical features of the patient, monitored over time. And IRIS will, I believe, for the first time, allow a disease process and the physical interventions that we do to improve it to be monitored. That is extraordinarily exciting. There are other implications, or regulatory implications and so forth, and for that I'll turn it back to Dr. Rich.
Thanks, Dave. I think one of our, I think it was in February of 2012, where we started to put together a group of men and women to design the registry. What was the optimal design? And actually to enhance this and the participation, the more docs that participate in this registry, the more powerful the data. We plan on having about 2,000 docs. Our goal was by 2015. We may do it by the end of the meeting. But if you have 2,000 docs in this thing, by 2017, you're going to have 18 million patients. That's quite a database to look at the impact of new drugs and devices. But to also increase, our focus was to increase the value proposition. And basically, as you heard in the opening session, we're moving from a strictly volume fee-for-service basis to value. And there's a lot of hoops to jump through. So basically, the regulatory benefits, if you look at the slide, you're able to really satisfy many of these mandated quality improvement programs. And you look across the bottom, and that's a nice schema, but the important one is the next slide, where it really shows the financial impact. The administration, and this is bipartisan, by the way, this is not from the Obama administration. Value-based concept started in the Bush administration. Basically, they've realized that human behavior can be impacted by small penalties much more efficiently than bonuses. And the impact on the bottom line, as David and Michael and any physician will tell you, of a 5% cut is a lot more onerous than a 5% bonus, a lot more beneficial, a lot more onerous, and less impact. So if you look at 2014, you see the impact. Let's scroll down a little bit, and you can see the impact on the value-based modifier, PQRS. Let's go back, sorry. So the impact of the data and the quality metrics that you, to jump through all those different hoops in the previous slide, look at the impact in 2016. It's at least 5%. Those are ongoing penalties, which after 2 years make a practice unsustainable. And so basically, we've looked at the regulatory impact of this. So it appeals to not just qualiholics, as I learned that word from ACC, those that will improve their quality at any cost, but for regular practitioners like myself. So the value proposition is there through the meeting of the regulatory requirements to eliminate those onerous cuts. Also, there's the possibility in a proposed rule that we might have to report on 9 measures. So some ophthalmologists are saying, hey, listen, I'm actually doing okay by reporting with claims, so you can avoid the penalty now reporting claims 80%, 3 measures. If they increase it to 9 measures, there's no way my practice of 11 physicians can ever comply with that. So the registry enables them to help not only the current demands for regulatory requirements and meeting quality goals, but projected ones, and actually takes away all the hassles of trying to redesign my office to meet those criteria. So I think that I'm going to turn it over to Michael now. And Mike?
Okay, thanks, Bill. What I'll be talking about is current status of the IRIS registry in terms of who's piloting it. And the reason that that's important is that, for the reasons that Bill and David talked about, the IRIS registry really lets us go beyond, what am I doing with my one individual patient who's in front of me right now, toward what am I doing with my population of patients compared to all of the other doctors who are out there taking care of similar patients. So in other words, we're really kind of harnessing that collective experience and collective knowledge of ophthalmologists throughout the country for these purposes of things like quality improvement and knowledge discovery on a large scale. And so the obvious question then is how many people are using it right now, and what do we expect to get out of it? So this slide summarizes who is currently piloting the IRIS registry. So there are 124 practices throughout the country, and each practice can have multiple locations, and so it's 332 locations for those practices. So in total, 685 providers. Okay, and for those 685 providers, so far, 370,000 patient encounters that have been loaded into the IRIS registry. Okay, so these aren't theoretical data, they're real numbers that are in the registry right now before we've actually even gone live with it. Tim, if you can go to the next slide, please. So for those practices, this is a geographical distribution of where they are. So it's basically 35 states. And again, the full rollout of the registry, or the official go-live date, if you will, is April 2014. So these are the practices that are contracted as of right now.
Looks like there's a lot of qualiholics in Texas there, David.
Tim, if you can go to the next slide, please. The way the registry ideally works is that the practice, we take a practice that's using the electronic health record system. And because the EHR stores data electronically, you can then much more easily transmit that electronic data to the registry. And what that requires is a mapping process where the registry vendor, which Tim will give a demo of that later, the registry vendor maps out for the data fields that we need in the registry, where are they stored in the EHR. Okay, so in some ways that's an EHR specific process. And this slide shows the different EHRs that have already been mapped to the IRIS registry. There are 11 or 12 of them right now. And this captures, there are a lot of EHRs for ophthalmology, but this captures a significant percentage of what's being used by ophthalmologists in the real world. The important point of this slide is the last bullet point. Tim, if you can go back, which is that IRIS registry can work with any EHR. And these are the ones that have been mapped so far with those pilot sites that we talked about on the previous slide. So if you can go to the next slide, please. So these are some more numbers here in terms of what's expected in the future. We talked before that currently there are 370,000 patient encounters in the registry. Before the full rollout in 2014, April 2014, we don't know what to expect. And the projection that Bill talked about for 2016 is 15 to 20 million patients in the registry. And that's based on an assumption that each ophthalmologist sees roughly 7,000 to 8,000 patients per year, patient encounters per year. And if we'll have 2,000 plus physicians in the IRIS registry by then, that's where we get the 15 to 20 million patients from. Okay, so big data. And if you can, the next slide. This summarizes what's coming up in the future. So these are things that are actively being worked on now by a registry group that Bill Rich leads. The IRIS registry will support the American Board of Ophthalmology's maintenance of certification, so-called practice improvement modules, by automating the collection of data directly from EHRs. And what that means is that the American Board of Ophthalmology is the certification body, so we're all board certified as ophthalmologists, and every 10 years you need to recertify. And to do that, the practice improvement modules are part of that process, where you have to, for a certain number of patients, usually with common problems, review the charts and pick out data elements to demonstrate that you're doing the right thing as an ophthalmologist. And the way that's done right now is that that's a really laborious manual process where you'll physically pull out the charts and read through them page by page and pluck out the data elements. It takes a really long time. And through work that Bill has done, our group has worked with the American Board of Ophthalmology to try to map the practice improvement modules to the data dictionary that we've got to be able to automate that process. And the hope is that that would make things much more efficient for ophthalmologists as they're board certifying. And I think this is a great collaboration between the American Academy of Ophthalmology and the American Board of Ophthalmology. The next bullet point talks about subspecialty outcome measures, where Bill's group has worked with subspecialty organizations within ophthalmology to develop measures for the registry that are relevant to subspecialty practices, things like cataract, glaucoma, retina, pediatric ophthalmology. And so these include both medical outcome measures as well as surgical outcome measures. Another future development is going to be enormous infrastructure for things like clinical research and post-market surveillance studies, where here the example is that there are always new drugs and new devices being introduced on the market, and the questions are, do those drugs or devices cause unintended side effects or have bad consequences that we don't know about? And with the registry, we're going to have this repository of 15 to 20 million patients where you can search for those complications and side effects. So major benefits compared to the way that we do it now. So I'm going to stop here and
Great.
take it.
Thanks, Michael. What we're going to try to do is give you some screenshots of what the docs will see in their office and how they can manipulate data. Physicians will improve if they're presented risk-adjusted data. We're pretty competitive. And certainly the concept of measurement followed by improvement has been demonstrated in other aspects of our society for 60 years. So Tim and I are going to show you a couple screenshots and the power of this as for an individual. Here's a couple of the measures now that are out there, and I apologize, I just want you to give an idea. You're not going to be able to see in a great deal of detail. This shows the measures that are out there now. You will be able in real time to look at your performance of measures, how they relate to, and you can compare it to your own group, your own region, or a national database, your own specialty. And there'll be flags on when you're lacking appropriate performance on those different measures. I think that this is what the docs will see on an ongoing daily basis. And you can actually express this any way you want, with bar graphs, dials, gauges, to show you where you need to improve and where there's deficits in your performance. Tim, why don't you show us some of the other screenshots, maybe the cataract one.
All right. Okay. So we go down. You have the default dashboard that has all of the views available. The quality summary.
Here's your measures.
Yes. The quality details will give the practice administrator or the physician the view of the data in several different methods. You can take a look at the practice administrator, which is how I'm logged into the screen. The practice level detail, for example, provider level detail, would give the administrator a snapshot of how each of the providers in the practice are doing. Of course, we have test provider information in here right now, but you can automatically see that, say, provider 1, provider 44 are falling below the standards, which the red line indicates the practice score. The gray line indicates the national average or the national benchmark provided by CMS. So the table to the right gives another view of the information, but it's not just a static display, it's interactive. So if you wanted to see, for example, why provider 44 maybe had three patients for that time period that did not meet, you can actually click on that data or that field and it will pull up a display and give you patient information. So you can go and do additional research, patient name, medical record number, date of birth, and gender.
That's very important to the physician. So if they didn't meet a performance level, it's useless if you can't go back and look at the individual patient and reconcile what you did, what you documented, and what the expectations are. So this gives you immediate feedback and gives you, without personal feedback on what you have to do to improve.
Below that is a location level detail for the practice administrator, so you can see how each of your physical locations are performing. And again, you have the same drill down capabilities in the table to the right.
As a practice with 3 sites and 11 physicians, we now look at each one of our sites on productivity, RVU, projection, and overhead. Now we'll be able to match each one of our sites and those units of care delivery, how they match up in quality too.
Absolutely. Many of our views are customizable, so if you did want to see all the providers, you could actually pull down this box and select only those providers that you wanted to monitor.
I think the real power of this is the ability to make queries and answer clinical questions. So why don't you pull up some on diabetes, Tim?
All right, in our analytics section is a place where you can truly put together on-the-fly reporting, and it's as easy as drag and drop the fields that you want to see. This is a blank slate. In the interest of time, we've taken the liberty of building a report here that's taking a look at patients that are diabetic with diabetic retinopathy, and then also been diagnosed, yes or no, for macular edema. And we're interested to see those that are on insulin or metformin. So these fields are filters, and we can very easily add or modify. Let's say that we're more interested in, we wanted to add another field here.
Age?
Yeah, so we want to see age, we want to filter. So we simply pull down the list and we would take our age group and drop it on the list over here, and then it will calculate. And I'll zoom in here a little bit, that may help you see a little bit better out there. So now, and we'll expand all so that we can see. So now we've had the added information for age groups.
I think the advantage here is that there are some discussions, as there are in all, whether it's cardiology, ophthalmology, endocrinology, of claims of different medicines. And there are some claims that some of the oral agents we take for adult onset diabetes have different impact, even though the hemoglobin A1C or the control is level, there's different end organ impacts. So now we'll be able to look at a database, not only in my practice, but a national database, to really see which one of these 4 oral agents is associated with a higher degree of macular edema? We don't really know. So that's the power of this. If you look specifically at ophthalmology, we're now measuring complications within 30 days of cataract surgery. You've all heard of the impact of, what's the name of the drug? The Flomax. And Flomax is associated with a dramatic increase in significant complications of surgery. Several years ago, brilliant David Chang looked at this and he said, you know what, I'm having an awful lot of complications. He's maybe the leading cataract surgeon in the United States. So he took some poor fellow and he made that person go through all of the charts and then all of the videos of every complication he had. And a couple of years later, he said, oh my goodness, 85% are men. And then he tried to figure out why that was. He went back and looked at the videos and then they decided, well, let's look at the concomitant diseases. And then they looked at medicines. They're all on Flomax. So something that took 5 years to address, with a click of a button now we'll be able to ascertain that. That's the power, the beneficial power and the concrete power. This isn't even big data. This is actually real data. So I think that gives you a flavor of why this is attractive to physicians. One other thing that David talked about this morning was research. There was a great article in New England Journal, and those of you that are interested, and we'll forward it to you, that showed the incremental cost of bringing a patient into a randomized clinical trial. I believe it was Sweden. Wasn't it, Michael, where that paper was written? $50 versus a couple $1,000s. It's going to revolutionize clinical trials. Right now, randomized clinical trials, they're homogeneous populations, and then you're off to the races and you're delivered to people of all ages, sexes, concomitant diseases. You'll be able to really look at a heterogeneous group of people and control different factors that you want to look at. So I think it's going to revolutionize the way we do research in the United States too. So thanks, Tim.
Oh, thank you.
I think what we want to do now is answer some questions. I think the value of these interactions in the past, getting some, it's like a Catholic church. People sit in the back but you know, please talk. Yeah.
Here, 1 minute. Could you say your name and who you're with, please?
I'm David Kellner with Methodist Communications in New York. And what does it cost the practice to join, or does it cost the practice to join? And are there reasons why a physician or a practice would not join the registry? What are the potential downsides?
Mike?
In terms of cost to join, the structure, monetarily, the structure that the Academy has adopted is that the registry is free to join for 2 years for the first 2,000 users. After that, it really hasn't been determined. In terms of time cost to join, it takes a little bit of time to map the registry to your EHR. And the experience that we've been having from FIG, MD, for the pilot sites is that it takes an IT person 1 to 2 hours per week for 3 to 4 weeks to do that. You know, it's a series of conference calls and reviewing the data. And our goal is that it shouldn't take the doctor any extra time, because at that point the EHR would be already mapped to the way that the registry would be already mapped to the way that you do things. And so in the process of your normal workflow, the data would all be collected.
I think that, to answer your question, we don't know what's going to happen after 2000, but I think David can speak to what the philosophy of ACC is. You still don't charge for your registry
No,
participation?
we do not charge individual physician offices for our registry participation. We do have institutional registries, and there is a fee for those institutions. Our outpatient registry, which is referred to as Pinnacle, the corollary, if you will, of the outpatient part of IRIS, is not one in which there is a fee.
I think the second part of your question is, is there a reason you wouldn't participate? If you have a paper chart, forget it. It's too disruptive to office flow. There is a web-based alternative, and I know that wouldn't work in my very busy clinical practice. I think the reality, it's available, and there are some large hospital system in New York that's just going to do the web-based surgical outcomes without using EHRs. But this is designed as what Michael and David talked about, to really extract it from an EHR. So if you're an EHR, it's kind of, why not? If you have paper, why do it? And if you have wanted to take a web-based portal, you better have a lot of staff and time and really be dedicated.
If I can make one more comment to that. I think that at the end of the day, every physician has one goal, which is to be able to take better care of his or her patients. And one thing that we know out of measurement data is that when doctors see how well they're doing or where they can improve, they'll get better. So in other words, it's oftentimes, I think the challenge is that we don't really know how we're doing compared to other people and compared to how we should be doing. And so from that perspective, it's our hope that every physician is going to be interested in participating in the IRIS registry as a mechanism, number one, to improve quality, and number two, to contribute to this overall body of knowledge that then all of us can use to harness for things like future knowledge discovery and research. And those are the things that Drs. Rich and Dr. May had talked about before.
Some of the other issues, why are we doing it now, is the ability. The whole concept of measurement and improvement is not a new one, and we talked about this briefly in the opening session today. Lord Kelvin, our European colleagues let us know, it wasn't Deming that first coined the phrase, if you don't measure it, you can't improve. That was Lord Kelvin in 1880, and Richard Deming made a fortune as a business consultant taking that and applying it to industrial processes in Japan. And now it permeates all of retail and most businesses in the United States. So this is not a new concept of measurement, but actually developing the metrics and how we measure it, and the technology is why we've lagged behind other parts of society.
Can you talk?
It's on. Speak
Hi,
up.
Howard Larkin at Eurotimes. Can you expand a little bit on developing the data sets that you're collecting? How is that done, and for what subspecialties or conditions do they exist?
Mike?
I think that's a really important question, because the question, really, to paraphrase, is what steps are we taking to identify the most clinically relevant outcome measures for general ophthalmologists and also for subspecialists? So in terms of the subspecialty piece, what we have done, again in a group that's being led by Dr. Rich, is worked with all the major subspecialty organizations. So identify key opinion leaders in those subspecialty groups as to what are the key outcome measures that are important, clinically relevant, measurable, and have worked to develop those measures, and basically gone through this process to calculate that measure. What are the data elements that are needed? How would we get that into the IRIS registry? And that's what we're working to build on right now. So it's a real collaboration between the American Academy of Ophthalmology and the different subspecialties and the subspecialty societies around the country.
I think ACC had a big advantage in that they were up and running sooner, so they have many more measures than we do. How many measures do you have? Like 33, 39, 40 measures. And we're developing those measures now. The advantage that we have over Dave is we don't have the laborious process of going through the National Quality Forum, which would have taken us years. We're able to develop our own measures. They have to be meaningful. They have to have the same scientific criteria. They have to be tested. So they have many more measures up and running. We have fewer. We are going to be able to measure, as Mike said, all the subspecialties. And I think Dave emphasized that this is an ongoing living beast. This is not a static process at all. Learning isn't, improvement isn't.
I'd like to make a comment. I think your question is extraordinarily insightful because it comes to the heart of what this really does. the usual concept is the registry is going to be a way to electronically monitor the quality of what we are doing, or my ophthalmology colleagues are doing. I'm going to be hateful. He looked at me to try to remember the name of the drug Flomax, which is for your prostate, so I'll leave that. It's an age-related thing. I'll get back to that later. But the importance...
Just don't drink much water.
Exactly. Why? Let me don't keep the water. But the importance of the registry and the data elements that are included are the identification of what in the world don't we know. Because it is within that framework that the registry shines. Now, I am not a nice man, as all interventional cardiologists are, so I do not typically send the 66-year-old golfing on a baby aspirin a day patient. I send the 74-year-old who is on 15 drugs, has a defibrillator, and a 25% ejection fraction. We don't know what happens to those individuals. They are not in randomized trials. They are never allowed in them. So that your question, which metrics we measure are the ones we know to measure, the ones that are nationally monitored, that is true. But the astounding piece of data registry collection is what you find that you did not anticipate. Not just that we're not doing a good job with this, but oh my goodness, did you realize that if you take Avandia, your glucose is better, but you die of a heart attack? Yeah. That type of information is breathtaking. And if we move up one more level of abstraction, imagine if I could mesh my registry data, my patients and their diseases, with his. Could he tell me from an ophthalmological investigation, this patient is one who is prone to heart attack? Now we begin to have tremendous surges forward with very little cost. And that, I think, is the beauty of the registry.
Is that something that you're considering at this point, or being able to integrate the various specialties to maybe do a broader population health approach?
That's really a great question, and this is the dream, what Dave just described, and there's something called National Quality Network Forum, something like that. What is the name, Kelsey?
NQF.
It's the National
Quality Research,
Network.
right? Registry Network, where they're actually talking about on a theoretical level how you can incorporate or merge some of these registry things. There's huge questions about diabetic macular edema, diabetic retinopathy, how it relates to hypertension control and cardiovascular disease. Same thing with, quote, low tension glaucoma, the use of drugs like chloroquine. Drugs, and it has a huge impact, we think, maybe on low tension glaucoma. We don't know. And to do that, I would like to get to import some of the control data on hypertension and some of the other medicines they use. That's pretty tough stuff, but that's the dream.
If I can make one other comment to build on that, is that some of these things that we're talking about could be done using individual registries. In other words, IRIS registry will contain what medications a patient is taking, whether they have hypertension, all those. Now, it's not going to have the level of detail that the ACC registry would have about those things, but we will know all those basics that we would normally capture in the medical record.
I saw a hand over here.
Okay, sure. Hi, Walt Bethke with Review of Ophthalmology. I was wondering, are there any plans, or do you envision the possible use of the registry as a revenue stream for AAO for companies that might, because you would have a massive amount of outcomes data on their drugs and interventions that companies would be very interested in that they do.
I'll make some comments. Our business plan is not finalized, and outpatient registries don't have revenue sources like NCDR, where hospitals pay a fee for looking at implantable devices and stents. However, there is a potential revenue stream for large amounts of data that device manufacturers and drug manufacturers would be interested in. We present this as an abstract concept to the foundation, and those corporate members, our light bulb goes off. Dave, do you have any knowledge of what business plan you guys are looking at for Pinnacle and other? Don't have a typical revenue stream, from like a tab or something?
As a statement today, the answer is no, there's not a way to do that by virtue of a variety of different issues that exist in the data sets. If we begin to move an order of magnitude in abstraction upstream and we begin to talk about randomized trials from registry data, then there does become that as an opportunity. There are also other opportunities which again are in that realm of after a couple of glasses of wine we talk about. Imagine matching a genomic database to the clinical database. Now we begin to recognize that this particular genotype is prone to the development of this phenotypic disorder. And there are revenue opportunities in that environment. But currently the answer for us as a cardiology group is no.
There are a couple centers that are looking at this. Mount Sinai in New York has a large genomics program. They're really excited about the clinical registry, and they're excited about Pinnacle and other registries to try to link their genomic base now to clinical registries. So there are some people that are thinking downstream or upstream.
Are there any other questions?
I just had a follow-up request. Thanks.
Follow-up?
In the registry, what security measures are on the data, like in terms of like how much identifying information will be in a in a field or file?
That's a key question, Michael.
The data are identified data, and the reason for that is that the registry is it's certified for PQRS data submission, and so then the key question becomes, well, how do you protect that data? And what's happened is that it's stored securely in the cloud based on sort of the highest industry standards. So obviously fully HIPAA compliant. And for example, the registry data are stored separately from the PHI, the Protected Health Information, and obviously everything that gets transmitted back and forth is fully encrypted.
I think that that's a key question. So it has to be identified so that I can improve. It has to be identified if I want to send it to CMS. After that, it's the aggregated data is de-identified. Tim, do you have any comments on your security?
No, as Dr. Chig said, it's we do split off the PHI from the clinical data and store it in separate locations, fully HIPAA compliant, fully encrypted. But as Dr. Rich indicated, we do need to have the ability to reflect the identification back to the provider. The providers and the practice administrators are the only one that can see that identified information. The aggregate data is anonymous.
Any other questions? Well, I appreciate you taking the hike down here from the opening session, and enjoy the rest of your meeting.
Thank you very much.